I'm a state representative from the state of Alabama, where I chair the Health Committee, and I'm also vice chair of NCSL's Health and Human Services Committee. Medicaid continues to take up a large portion of all of our state budgets and remains one of the biggest challenges for lawmakers in terms of anticipating and controlling cost. Today, we will hear about recent state innovations, such as payment and delivery reforms that show promise in terms of helping states improve program efficiencies, which I know is very important to all of us. Today, we have the privilege of being joined by our panelists, Senator Monez Anderson from Oregon, Senator Watson from Tennessee, and our moderator, Kathleen Nolan. Kathleen is a managing principal at Health Management Associates and brings with her a wealth of Medicaid reform and innovation expertise. She previously held the position of Director of State Policy and Programs for the National Association of Medicaid Directors. She did that for 12 years, and she's also been a Division Director of Health at the National Governors Association. Senator Monez Anderson is a registered nurse. She's been an Oregon State Senator since 2004. As a county public health nurse, she's worked in a variety of areas with drug-addicted moms and babies, at-risk seniors, and at a school-based health center. For the past few sessions, she served as the chair of the Oregon Senate Health and Human Services Committee. Senator Watson is a state Senate Speaker Pro Tem and first vice chair of the State Senate Health and Welfare Committee. Senator Watson's been a practicing physical therapist for 25 years and is currently the Director of Therapy Service at Park Ridge Medical Center in Chattanooga, Tennessee. Again, I'd like to welcome you to this session, and Kathleen, now I'll turn the stage over to you.
Great. Good morning, everyone. Really looking forward to this session here today. We are, as panelists, we have been discussing this and really want this to be an interactive session. So we're going to give you some information and then hoping to really dive into discussion. As Representative Weaver said, my experience in the past 12 to 15 years actually has been working with a lot of state and federal policymakers, particularly on Medicaid policy and Medicaid reform. And I think that to a large extent, we sometimes get accused in the Medicaid world of purposely making things complicated. And I don't think that's so much true. It is really complicated, but our hope and our intention here today is to try to help sort of give you an insider's view to some of these, some vocabulary for working on these issues. And as we see from the poll you all have been answering as you've come in, a lot of us are in that we know some, we're trying to get our feet underneath us and really move some things forward, but we even have some beginners, and so it is really important for us to get a firm understanding. And so what we're going to do today is kind of talk to you about what's the vocabulary, what's the activity that's going on in innovations across the country in Medicaid, and then really, I hope, have a discussion about what you all are needing and thinking about and what we can do to help you think that through. As Representative Weaver said, of course, the program is continuing to grow. More people, more money. But I think one of the things that we don't spend as much time talking about is it's also really becoming more and more complex. And so I think one of the things that we really need to focus on is that organizationally it's becoming more complex. The people who are enrolled in Medicaid have many more and quite varied needs in terms of the kinds of services that they require. And so it's not just growing in numbers and in dollars, but really in sort of what the scope of the program really is. But also as this complexity grows, we have a lot more stakeholders who are very interested in the program's success and operation. And so we're going to talk a lot about not just the innovations that are happening, but who the stakeholders are that we need to involve. So in response to the growing pressures from all sides, all of you and many other stakeholders and state leadership are really trying to look for ways to make the program operate more effectively and more efficiently. And a lot of this has been bucketed into a very large category of activities that we call delivery system and payment reform. And so what we're going to try to do is give you some ideas of what that means because it's a very large set of activities. And so my intention here to start us off is to give us some vocabulary, some ideas about how to talk about this issue and where we are on it. One of the most frequent phrases out there right now in Medicaid reform and increasingly in Medicare reform, which we can touch on more if we want to, is the concept of value-based purchasing. And this is a very simple idea, but has many different ways that it looks. So it's really just about paying for outcomes instead of paying for numbers of procedures. And so that's a simple concept with many different expressions. So some of the things that we're seeing out there are ideas about paying for performance and outcomes. You're seeing the use of incentive pools where people are pooling dollars and then you're distributing them based on performance in some way. You're seeing some concepts called shared savings, where simply if we're collectively seeing some improvements in cost performance of the program, we're going to share those between the state and with our providers in the community. And so that's a concept that you're hearing a lot, and I really suggest you tune into the value-based purchasing conversation. Another issue that we spend a lot of time talking about is the concept of integration. And as I said earlier, our Medicaid enrollees are quite complex. They often have a lot of different needs. Increasingly, you're hearing conversations around, for example, behavioral health issues. Medicaid has, for a long time, been a pretty big player in the behavioral health space, where we've been paying for a lot of services, behavioral health services, and by that I mean mental health and increasingly substance use disorder services. And in the past 10 years, we've become the biggest payer for those services anywhere. And so I really think this is a critical set of issues. And the idea now is that we have to be better about integrating care between the behavioral health side and the physical health side, because we can't take care of those two things in silos. And so there's a lot of conversations in the delivery system and payment reform that really get into behavioral health integration or other kinds of integration. You're seeing things like health homes, accountable care organizations, and other types of arrangements that are really trying to bring all of the different providers for different aspects of Medicaid under one operating principle. And I think that's a really important concept when we're thinking about efficiency of the program. We're going to be more efficient if we're working together. Another important concept in Medicaid innovation is a simple one, again, follow the money. There are individuals in our Medicaid program who are using a lot of services and a lot of your Medicaid budgets in a small number of individuals. And so it's really incredibly important to think about how you're focusing and targeting your interventions on some of those individuals. Sometimes they're called frequent flyers or super utilizers. But the concept is really the one that you've got your entire Medicaid population, and you could focus, and you should focus on some innovations for the whole population, but you've also got some opportunities to really dig in and work with some individuals who are maybe on the side of of using more of your dollars. And so you're seeing things, as I said, with the idea around super utilizers, and then a lot of emphasis on long-term care, long-term services and supports, and how are we doing those in Medicaid, and how are we innovating in that space to make the program more effective. And then I think you'll hear a lot of examples in this, in our conversation, I'm sure, as well as from our two senators here, about community-led efforts. So obviously you're working at the state level and working on state policy efforts to do Medicaid reform, but a lot of emphasis now is being put on how can we empower communities and make them accountable for doing this on a community-by-community basis, because the communities might vary in what their needs are, what their Medicaid populations look like, and some other aspects that I think are really important. So that's some of the places where Medicaid innovation is putting some emphasis. And I want to talk for just a minute or two about, okay, so if you've picked a target or you've picked a place where you really want to make some progress in your Medicaid reforms, what do you need to do that? And so I'm going to talk a little bit about essentially the tools for reform. And what's important is the tools are the same kind of no matter what area you want to work on. So we'll sort of talk about it at that level. And I really encourage you, as you're listening to our senators present their stories from their states, think about how those, what sort of tools you have that would be available to you to move forward on these initiatives. So It's a complex area, as I said. You have to pull a lot of levers to make reform. And one of the most important, I think, is really the issue around having information and data and being able to analyze it, to be able to understand what's happening in your communities, what's happening for your Medicaid enrollees. And so one of the biggest tools for Medicaid reform is really data. It's information and the ability to use it in analytical capacity. And so I think that's one of the biggest pieces. Another pressure point and another tool for you is contracting accountability. So as a public program, you have an opportunity to leverage how your dollars are used and what you get for your dollars. And so looking at your structures, your ability to, for example, competitively contract and to enforce what you want to see out in the communities through your contract vehicles, I think is a really important place. And then how do you oversee those contracts? Once you have a contract, either for managed care or for an accountable care organization, how do you make sure that what you want to have happen is happening? So I think a lot of the accountability structures are important. And then, as always, payment. Payment reform is increasingly the way that we are going to actualize what we're all talking about. And that's an uncomfortable conversation, right? No one wants to talk about their money. They want to just do it, and they promise they'll do it, and let's just move on. We don't have to be hijacked here. But we know to a large extent that if we don't have some sort of incentive for engagement, it's much harder for us to make progress. And so it is a place you kind of need to go. But it's one that increasingly we're trying to find creative ways to talk about payment and not just make it a hammer, but one that we're really trying to drive the conversation towards quality and towards value using money. And then I think the ability to organize at the community level is another thing that states can really use as a tool. Providing the forums for communities to get together, to understand their challenges, and to work out solutions to fix them. So a lot of people are taking a community level approach to Medicaid reform, and one that I think you all can consider. And I think probably the most important aspect of any of these is we have to have the providers on our side. We can't do these things without a committed provider environment. And so I think that as legislators and as people who work on that side, I think that's really an important part, is you got to figure out how to get your providers to come along with you. And those are really tools that you can apply to any of these models that are out there for Medicaid innovation, the data, the money, the contracting, the communities, and the provider buy-in. So Samantha, if you want to go ahead and turn to our next question, I wanted to sort of put up our polling question here to talk about. Is it up there? Oh, perfect. Okay. So we're gonna go ahead and give you a picture into two states here about their particular reform efforts. And wow, everybody's in advanced already. Okay, well, we'll work this out. Perfect. Well, I don't know why we're here. So what we'd like you to do is take a few minutes to just sort of tell us where you are. Regardless of whether you're a legislator or just in the community, what's your opinion about, it's dropping, there we go, that's closer. So what's your opinion about where your state really falls on this spectrum? Are you in a state that is just gung-ho, driving towards reform? Are you in a state that's going, really don't want to play, but I think we're going to have to? So go ahead and give us your opinions on this, and I just wanted to talk for a minute about what we're going to try to do. So I think to a large extent, when you look across, there's probably some of the kinds of innovations that I mentioned being considered or implemented in your state right now. Small scale, large scale, those kinds of things are certainly playing out. I would suggest that you will probably need a number of different innovations over the next few years to actually get the kinds of efficiency and effectiveness improvements that I think we're all looking. But I also wanted to mention, and you'll hear this, I'm sure, from our two state examples, but this is not easy and this is not fast. And so I think one of the most important parts of engaging in the Medicaid innovation space and in delivery system reform is you got to sort of set your own internal expectations. It's going to take more time. than you can possibly imagine. It's going to be harder and probably produce less than you would like it to, particularly early on. And so I really encourage you to not relinquish your efforts, because it is going to be something that I think you will see progress is being made. And so if we all stick with it, I think that's what we're going to be able to find. So we do have, our polling results are in. We do have a lot of states that are in the early or just early stages or recently launched initiatives. We have a few states that feeling like they are quite advanced and are really moving the needle quite a bit, or doing a lot of activity. And then I think, and not surprisingly, about a quarter of you are thinking, I don't know what our agenda is going to look like. And I think that's reflective of where we are in a lot of different spaces. So hopefully we'll hear some good examples here today and get some conversation going to really see what we can do to help you all move up that scale. So with that, Senator Moynihan Sanders, you want to go ahead and talk a little bit about the Oregon experience?
Great. Can you all hear me? I am from Oregon. I'm a state senator. I've been chairing the Senate Healthcare Committee since 2004, and that's when our transformation happened. And believe me, being a healthcare provider, I thought that I would know a whole lot about Medicaid, and that was not the case, and I am still learning, and it's gurus like Kathleen that can help us keep on track. We have made a number of changes in Oregon, and for a variety of reasons, but we knew that our physical health and our behavioral health, our mental health, dental care, public health, they were all silos, and they were all costing our state a lot of money. So what we did is we developed what we call the coordinated care model. And we had a huge process where the governor pulled all stakeholders together. I mean, we had legislators, insurers, healthcare providers, hospitals, dental, alcohol and drug, physical therapists, chiropractors, yes, naturopathic physicians, consumers. We all were at the table because we all had a vision of how we wanted healthcare to be delivered and provided in the state of Oregon. And we now do have a coordinated care model. We have 16 coordinated care organizations. So every part of the state has a CCO, a coordinated care organization. Now we have more than 1 million Medicaid members that are signed up in our CCOs. And we are an expansion, Medicaid expansion state, which added about 400,000 Oregonians. It didn't change the demographics too much except age. So we're getting a lot of those 19 and older. What is a coordinated care organization? It's a network, and it has all types of healthcare providers. They have the physical health, addictions and mental health, dental care providers. They have all agreed to work together in their local communities to serve people who receive care coverage under the Oregon Health Plan, which we call Medicaid, our Oregon Health Plan. It's working. We're still learning. Changes are being made, but Oregon is experiencing improved and more integrated care, and we are saving money. With a focus on their focus is on primary care and prevention, and health plans are using the care model, coordinated care model, to better manage the chronic conditions that Kathleen had mentioned that use up so much of our resources, and they're keeping people healthy and out of the emergency rooms. CCOs are local. They are governed by a partnership among the healthcare providers, community members, and stakeholders in the health systems, and they must have a financial responsibility and risk. Contracts are set up with each CCO. We have 16 in the state with the Oregon Health Authority. So contracts are set up, they have outcomes, and I'll get to that a little bit later. They have one budget. They are paid so much per member per month. And we call this a global budget. and they can use that money however they feel is appropriate. And there's a lot of flexible spending where maybe buying an air conditioner is going to prevent someone from keeping on going into the emergency room. So we do have, I think, a very innovative way of taking care of our patients. We have had runaway costs. 2 years into our system transformation, it's working. We are reducing waste, we're producing health outcomes, we're actually creating local accountability and flexibility and aligning financial incentives and creating really long-term fiscal sustainability. Oregon is staying within the budget that meets its commitment to the Center for Medicare and Medicaid Services to reduce the growth in spending by 2 percentage points per member per year. So it was 5.4% the growth per member per month each year. We're now down to just 3% per member per month growth percent. So this has saved the federal government already $1.4 billion. Well, they will say that within the 5 years. And it's on track to save $6.5 billion in the next 10 years. Okay, so what do these CCOs have to be held accountable for? It's in their contract. And they are, the Oregon Health Authority is tracking 17 CCO incentive metrics and 16 additional state performance metrics. And I'll get to what a metrics is. When you're using quality access and financial metrics together, the state can really determine which CCO is effective and adequately improving care, making quality care accessible, eliminating health disparities, which is huge, and controlling costs for the populations. We are paying CCOs for quality care, better health outcomes. We're not paying just for more services, as Kathleen had mentioned before. There are innovation payment methods and episode-based payments. The incentives for quality outcomes, that's what we want, not volume-based fees. So, of the 33 quality and access metrics, the CCOs are receiving incentive payments from a pool for making targeted improvements in the system and meeting at least 17 of the benchmark metrics that's in their contract. Now, if a CCO does not get all of its money back, that money goes into a pool, and it's called a challenge pool, where the funds are available for CCOs that are really high achieving in key metrics. And believe it or not, when you provide this incentive for them, they are trying very hard to meet those benchmarks. This is the third year of Oregon's pay for performance progress. And we still are taking some metrics off in the contract and adding some. The most recent one is sealants, dental sealants. They've decided to add because, you know, dental care is still, even though we have it in our model, it is very difficult to make sure that we have good outcomes in dental care. So we are seeing an increased rate in just 1 year of dental sealants. We have the emergency department visits have decreased by 23%. Hospital readmissions have decreased. There's and 29% for short-term complications from diabetes. It has decreased, like COPD, that's chronic obstructive pulmonary disease, that has decreased 63%. Congestive heart failure has decreased. These are readmissions, 29%. So we are saving money with this model. We now have a metrics on the percent of children and adolescents that must get a primary care provider. That is happening. We have now increased, another metric is a screening for depression. Again, it's increasing, as well as over 84% of our Medicaid population is in a primary care home. That is an incentive. It's up to the CCOs to make sure that every Medicaid patient is in a primary care home. And there are providers that are providing that. Yes, we have our federally qualified health centers, which are a part of this system, but there are clinics and providers that are also being considered a primary care home. We've increased the use of effective contraceptives. That's another metric. The percent of women ages 15 to 50 are now using an effective contraceptive, it's increased 9%. So as you can see, we have a number of metrics. We are seeing some issues and problems. We still have to develop some culturally responsive and population-specific training for providers. We are developing our health information technology services are going to be launched in 2017. We need to have more efficient and effective care coordination. We need more analytics, population management. You know, this is all stuff that I don't understand as a provider at all. She does, but I don't. We have some pilots on telehealth. A lot of our state is rural, and so we worked on legislation to pass telehealth pilots, and they are now working on a system. And if it's successful in one area, then hopefully it can be spread elsewhere. And I couldn't see. How much time do I?
I think just like another minute is fine.
Okay. So I'm excited, as you can tell. I think we still have a lot to go, but it is working, and we are saving money, and that is key, because I do believe health care is a right, and everyone should be able to have the opportunity to get health care. Thanks.
Thank you, Senator. And I think it's good to see this kind of excitement, but I think one of the things that you said that's so important is that it's an iterative process, and so we'll talk some more about that too. I think another thing I wanted to highlight is one of the most important innovation is a very simple one, which is keeping people out of the emergency room. We know that is one of the things that we know has been broken about our system, but it takes communities intervening, and I think that's a really important part that we can talk about some more in our session. This is really just to give you a flavor about what's going on in these two states, give you some baseline, and then we're gonna come back and talk a little bit more about some of the lessons that they've learned. But Senator Watson, you wanna go ahead and talk about Tennessee?
Great, Kathleen, thank you. I'm Bo Watson. I'm from the great state of Tennessee, for those of you in the back who can't see my name. And let me do a product placement here. The NCSL recently produced a paper on improving the healthcare system, 7 state strategies. Probably everything we talk about here today is included in this document, so I would encourage you to, do I need to move over closer to the microphone? Do I need to start over? Please? Product placement. So if you haven't received this in the mail, seek one out today and read it. It'll have a lot of the information that we will probably discuss with you. I noticed that about 20% of the people claim to be Medicaid neophytes. So let me quickly bring you up to speed of where we are with Medicaid. As you know, it started in the middle 60s. It's a supposed partnership between the states and the federal government. The reality of it is it's a one-sided deal. And if you think you're innovating, you're lying to yourself. You're not. The feds are telling you what they will or will not allow you to do, and most of the ideas that you're creating are being germinated in probably Northern Virginia or in the D.C. area. And they're coming out of some think tank, and they're being permeated to all of us here. And that's well and good, and they're good ideas, but the reality of it is because so much of the money comes from the federal government, they actually tell us what we do or we don't do with our Medicaid or our TennCare systems. Now, in Tennessee, in the early 90s, our governor then, Ned McWhorter, had a brilliant idea that we would be a state, a leading model of innovation in the Medicaid system. So we went to our friends at the federal government, who often aren't so friendly to us, and we said, hey, we'd like to create our own little system here using a managed care model. Well, at the time, as if you'll remember, those of you that were around, Hillary Clinton was pushing for a pretty strong health care program. Clintons were interested in that kind of innovation, which is either neither good nor bad. So Tennessee became one of the first waiver states, and we became, all of our all of our Medicaid patients were put into managed care programs, most of which had never operated any kind of managed care program in their insurance history, and it became a huge debacle. And over about a 15-year period of time, it went from consuming about 15% of our state's budget up and started breaking into the 35% of our state budgets. So in the early 2000s, the new governor, Governor Bredesen, looked at the rising Medicaid. Of course, the first thing he did was he hired some consultants to come in and look at our Medicaid system. And they came in and looked at the system and said, you know, you're spending too much on Medicaid or TennCare, even though it's managed care and it's supposed to help control costs. There have only been 2 states in the history of Medicaid since the 1960s that have actually radically changed it. Maine. Is anybody from Maine here? Yeah. Hey, there's a guy. Good man. Maine made some significant modifications to their Medicaid system, and Tennessee, where I was a member of the House at the time, and we cut our TennCare rolls, reducing benefits to the tune of eliminating 180,000 people. Now, those of you out in the audience who think it's easy to make those kind of cuts, let me invite you to come and visit Tennessee and see how people feel about that. Those of you that have expanded your Medicaid systems, I certainly, you know, that's obviously a choice each state has. But when your costs start to run away with it, you're left with a limited number of options or how you're going to control those costs. And so in about 2005, 2006, we cut our Medicaid rolls by about 180,000 people, creating a financially stable TennCare system. Still requires us to go to the federal government. Matter of fact, we're back this year asking the federal government for permission to continue our partnership with them in our TennCare program. Let me tell you how ours operates, and then hopefully we'll get into some good conversation and discussion here, because you don't want to hear me talk, and I get to ranting sometimes, and if I've already started, I apologize. Tennessee has actually done a lot of innovative within the confines that the feds will let us do, a lot of innovative thinking around Medicaid or TennCare, mainly because we have a pretty unhealthy population. I mean, look, we're not a wealthy state. We're not in Oregon. Oregon's per capita income is a lot higher than Tennessee's. Their standard level of education is higher than Tennessee's. We used to be, we're surrounded by some tobacco states like North Carolina and Virginia, so obviously over history we've developed some health disparities that create financial problems for us when you have a Medicaid program. But even within that milieu, we have been able to reduce the growth in Medicaid costs at about half of what all the other states do. So if your state grew at about 6% this year, which is about the average that most states did, ours grew at 3%. And the way we've done that is we've done a lot of different things around benefits. We've got some really good partners. Okay, the insurance industry takes a beating at a lot of different things, and sometimes I like to beat up on them because they're an easy target. But the insurance industry has actually been a really valuable partner to us. And if you're an industry representative here, we appreciate what you do, because we often ask you to do the impossible, and that is figure out a way to pay for health care for people who don't care about their health care. And that can be challenging. But one of the primary methodologies that we're now embracing is the idea of episodes of care. And if you're a provider and you're the quarterback of the episode of care, you're going to like it. And if you're a provider and you're not the quarterback of the team, you're probably not going to like it, because it uses basic capitalistic mentality, which is if I can provide a high-quality service and get a positive outcome at a reduced cost, and I can benefit or I can get incentivized by the savings for that, then I'm going to work really hard to make that happen. So what happens is, let's take a common one. Usually these work around standardized procedures. The most common one I'm familiar with, and your state Medicaid director would be familiar with, is total joint replacement. It's a fairly standardized approach. It's a pretty simple procedure. If you're trained as an orthopedic surgeon, if you're an insurance salesman, you try to do one, I wouldn't recommend it to you nor to the patient. But if you're an orthopedic surgeon, the way that a total joint replacement works, it's a 3-day experience for the patient for the most part. In that episode of care, you would make your orthopedic surgeon the quarterback of the team. Now, the more, and it's almost like a capitated system, so I'm going to make the math simple because I know I got some folks from Alabama here. So I thought I'd wake you up eventually. I tell you, I thought I was at the funeral home directors meeting here.
It's Medicaid.
Yeah.
And it's the morning.
So I'm going to pay, you're the quarterback of the episode of care, I'm going to pay you $100 to take care of my patient Logan over here, who actually, he staffs our health committee in the Senate. And you've got $100 to spend on all the services necessary to get that total joint done. That includes the payment of the implant, that includes the hospitalization, that includes all the other characters that want to participate in the care of this patient. Your job is to do it at $90 rather than $100, because if you save $10, I, as the payer, are going to provide you with an incentive for having saved those $10. So at the end of the year, I'm going to add up all the total joint patients you saw, and I'm going to measure you against all the other people who've done total joints in the area, and I'm going to decide, based on those metrics, whether you get incentivized or, guess what, you owe me money because you didn't keep to the plan of keeping costs down. And that uses capitalistic thinking or the profit motive in order to try and help drive costs down. That's one methodology that we're using. Now, here's the challenge. If you're not the quarterback and you're not the one incentivized, then you may not benefit quite as much as the quarterback does. And so each episode of care may have a different quarterback. Like, for example, perinatal care often has the hospital as the quarterback. Your Medicaid directors, they know all this stuff. And if you don't have a relationship with your Medicaid director back home, you need to get one. And if you don't have a relationship with the chief financial officer of your Medicaid program, you need to get one, because those folks are in the know. They really are. And while we can talk a lot about policy, they are much more equipped to talk about the details of how it operates. And finally, I'd say to you that if you don't have a good relationship with the industry that helps you with your Medicaid program, be it Blue Cross Blue Shield or whoever it might be in your home state, you need to have a relationship with those folks as well, because they are doing a lot of data mining to help them understand what drives health care and what drives patients to or from health care. And here's at the end of the story, and then I know you want to move along. The challenge that we have is like the challenge that we have in education. We have a dysfunctional system that we're now trying to superimpose other kind of systems on top of to try and make it work better. All the things that we're talking about here today, all of these things that are printed in here are creative ways of trying to work around a system that does not use normal economic principles. Because in all this conversation, the one person who never gets included in the conversation is the consumer. Because the hospital or the doctor or the physical therapist or the nurse or whoever the character might be, their conversation is not between themselves and their patient about how we pay. Their conversation is between them and the payor, who is a broker for the patient. And now we have to try and reinsert into the system market principles that normally operate in a market when there is a relationship between the consumer and the provider. And that doesn't exist in healthcare. That's neither good nor bad, it's just how it is. And so like education, where we know we have some faults in the foundation of how the system was built, we know for darn sure that in healthcare we have faults in the foundation of how the system was built. And so now we're trying to figure out how do we put into place some market factors that will help naturally drive down the cost of healthcare. Healthcare, like most products, will never go down. The cost will never go down. What you will see is, or what we're trying to do, is control how much and how fast the growth of the cost is. And as that technology advances, it will make the per unit of service less expensive. And for those of you in the manufacturing industry, you'll know what that means. But, you know, a television today that you pay $500 for, that same TV would be $15,000 in 1960 because technology just wasn't there. So the outlook for healthcare is incredibly positive. I don't mean to sound negative, but it tends to get people aroused when you're at these kind of things. But the reality of it is states need to stand up, and if we're going to be innovative, we need to challenge our partner around Medicaid and the federal level to allow us to innovate. One of those ways would be to allow states block grants to where they could do what they want to do with the money that they've sent in and the money that's come back. And I'll yield so we can have a conversation.
Thank you, Senator. I think one of the things you said that I was thinking about the states that we have here on the dais, and it used to be if you wanted to save money in a program, in the Medicaid program, you had three options. One was to cut people, like Tennessee did, and it was intensely painful and really still sort of struggling with that. You can shave services, and Oregon, in fact, has done an interesting concept with the health plan that they have, where they have sort of cut services. And then, I'm sorry, I'll call on Alabama, which is cutting rates right now. Those are your three cost-saving measures. And each one of these states has been through all of those, and they're still back here because really the solution for us all is to just flip the script. It's to do something different. And I think your point, Senator Watson, about we're going to get better at innovating. We're going to get better at reform, and it's going to come cheaper and it's going to come easier the more that we do it. And I really think that's where the point of where we are right now is. It is really hard to do some of these reforms, but it's getting easier as we all come at it and as we learn from both our mistakes and from our successes to really learn how to do it. I think it's going to get easier and easier as we go along, and we have to do it because we're just kind of stuck in where we are, and we've used a lot of the tools we have, and we have to come up with new tools. So I'm gonna ask you a question here. We have a polling question just really quickly, and I think both of our folks sort of talked about this. I think one of the pieces of this question is who do you think is the most important for you to engage in your Medicaid reform process? But I'll sort of ask this question: who do you not have on board? Because this room is pretty full, which means to me that you all are interested in least in engaging in this conversation. But I'd like you to take just a minute or two just to talk about who you need to bring along in your efforts. And while you're doing that, I'm going to turn it back to both our senators. I'm going to start with you, Senator Watson, and ask you a question. What would you say, of all of the things that you have experienced in your efforts in Tennessee, is the one that you want to make sure that they leave this room understanding? What's your big lesson learned that you want to make sure folks sort of come to on this? I know I sort of sprung that on you.
No, that's a fair question. Well, I think that the biggest takeaway is that whatever innovative ideas you have in your laboratory of democracy back home in your state has got to be packaged in such a way that you can get your partner at the federal level to agree to it. I mean, that's just the truth.
Yep.
States have and it comes down to the point that at the federal level, they don't believe the states will really utilize the money to the degree that the feds want them to. And quite frankly, administrations have made that statement. So I think to be honest, the biggest takeaway you need to take away from here, in my view, is that if you haven't met and sat down with your Medicaid director, you need to sit down with your Medicaid director. Because, I mean, there is a whole association of state Medicaid directors who look at all this together, and they're going to be presenting the nuts and bolts of this to you. And if you want to understand it, that's whom you need to speak with. Now, and secondly, that there is no one size that fits all, despite what national governments would want us to believe. What works in Oregon is not going to work in Tennessee because people of Oregon are different than the people of Tennessee. I assure you, the people of Oregon are different than the people of Tennessee. And we're all different from the people of Alabama, right? But I mean, seriously, each state has to craft a program, and that's, and I guess you can sense my frustration. That's my frustration is I don't care what they do in Oregon. Oregon elects people to make their decisions. If they want to expand Medicaid, that's fine. If they want to just give health care away in Oregon, that's fine. That's Oregon's choice. I want the liberty and the independence in Tennessee to make those same kind of decisions without somebody else telling us how we need to do it. And I suspect many of my friends in Alabama and Georgia and North Carolina and those that surround the 8 states that surround our state kind of feel the same way. It's easy to talk about innovation. It's tough to implement innovation when you have a partner who's making it hard on you.
And I think your point about understanding your own Medicaid program, I think, is really key too. I mean, and I think that is a critical component. But we can't forget that there is a partner in our current situation, and it is it's a hard relationship a lot of the time, and especially when it's about innovation. And so I think that is something to be watching. Certainly there's the changes that are coming at the federal level, and another thing to be watching. So something for you all to keep in mind, that even as you're going forward on your own pathway in your state, at some point, federal engagement is a necessity. And I think it's really reflective, too, of what you've got up here. And I think that's one of the most telling pieces, is if you have your stakeholders on your side, it's a lot harder for the federal government to ignore your request. And I think that one of the things we've seen, and I've been in Washington for, I won't even tell you how long because it's not worth mentioning, but too long, and that's true of anybody who's been there for more than a couple of days. But one of the things that I think is so important is that if you come with a good idea, the first thing they're going to do is call all your other folks, find out what they think. And if you come together and come with the idea, it's much more likely you're going to get somewhere. So just something to be thinking about. Senator Moniz-Anderson, anything you wanted to share about
I
that?
think every state needs to look at their system and figure out how they are able to reduce costs. When you look at the last 50 years, our wages have gone up 16%, but healthcare costs have gone up 818%. There's a huge difference, and if we don't get our costs under control, which we are trying to do in Oregon, our people aren't going to be able to get, there'll be less and less people getting either fewer services or cutting enough people so that they don't get any services at all. We do, so I think that's my key issue for you to take a look at and get everybody at the table. I think it worked so well. We met to try to come up with our model. The governor called us in every Wednesday night from 6 to 9, and there were about 70 of us, very well coordinated, and it worked like a machine, but everyone had a chance to give its input. But again, we need to look at, without decreasing quality care and making sure that people can get care, looking at how to reduce costs.
Well, and that's reducing cost obviously is a huge issue, because if you look at your who needs to be most engaged, you've got 65% of those folks benefit from the benefits that are usually provided in your Medicaid, or in our case, TennCare program. So the hard part about the negotiations reducing cost is that you're having to negotiate with the people that you're going to be affecting their pocketbook, be it the physician or the nurse or the insurance company, whoever it might be. And that's why the conversation is often difficult and is often non-productive, because, again, we're dealing with a system that has been built and designed around some perverse incentives, and now we're trying to roll back some of those perverse incentives so that the system can actually operate in a more economical fashion.
So we're going to turn to the audience for some questions, so I want you to go ahead and start thinking about what those are. But I think before we do that, I wanted to ask one more polling question, because I think this really gets to your point, Senator Moniz-Anderson, about the issue of the money, and yours as well, Senator Watson, because I think this is the issue of this is going to affect people, no matter how we think about it, and it is going to affect both on sort of the patient side in terms of what services they have access to, as well as what providers are paid. I love this; it's great. So this is really fun, real-time polling. I don't know; I'm going to have to get used to this, but I think it's really important to get your feedback, because I think this really helps us understand where folks are coming from. But these are the different people who are going to be affected, as well as the different systems that are out there in terms of what you're trying to tackle. Is there a particular place that you think your biggest, I'll say bang for the buck, although that's not quite where I'm going, but really where you think you're settling in? And really remarkable and not surprising to a large extent, though, is a lot of you see the behavioral health connection. I think this is one of our biggest challenges, And I wanted to get back to something that you said, Senator Watson, about
Lord, I've said a lot of
you
stuff.
said
I
a
can
lot of
only
stuff,
imagine.
absolutely, but it's all good. So I think one of the things is you said it's really hard to innovate in this program with the federal partner, but one of the things I've been fascinated by in the last few years, particularly around this behavioral health arena, is in fact, when you look across it, while it's hard as heck to do this work in Medicaid, we're actually leading the way. We're ahead of a lot of the other payers. I hear from private payers who have never had to deal with behavioral health issues. That's always been something out there, and suddenly this is more and more part of their purview. And likewise with Medicare. You know, Medicare is always sort of this big behemoth in the provider community that we have to kind of work around on a state-by-state level. And yet, they've just started to talk about value-based purchasing. You guys have been talking about it for a decade. You know, it's really interesting to me that even though it's really challenging in Medicaid, we're still often leading the way, which is both scary and important to recognize.
Yeah, and to the screen, the interesting, I guess I should have said when I was talking about those who may be new to Medicaid, you got to remember about, you'll know the exact number, but 40% of Medicaid dollars go to long-term care. Mm-hmm. So out of 60, you're only really spending, let's just simple math for our friends from Mississippi. Anybody from Mississippi here? There you go.
Easy now.
So every dollar you spend, you're only spending 60 cents of that dollar on actual health care. The other is on long-term care. And when you look at a slide like that, I get the impression that people tend to negate the long-term care aspect of Medicaid systems, which is actually, nearly half of it.
That's a really good point. And I think that I think a lot of times in the current environment, that has felt like a place where we don't know where our pressure points are. We really struggle to find them, and people are sort of like, can we touch it? And I think that's back to the stakeholder issue.
Well, I tell you who's done a real good job. So I'll give a shout out to our friends from Oregon. Actually, Tennessee traveled to Oregon. Let me tell you, it's a long way by horse and buggy, but we got there. Y'all have done a great job in your long-term care. Community-based services, that's another aspect. If your state isn't looking at it, I guarantee your Medicaid director is looking at it. On how you can, in essence, deinstitutionalize our long-term care services and provide more in-home, in-care services. Remember, 40 cents out of every Medicaid dollar is going to long-term care, so don't spend all your time talking about hospitals and doctors and nurses. You got to talk about the other side of the equation as well, which is taking care of folks who are reaching that point in life where they're no longer able to take care of themselves. And I'll yield to Oregon to talk about what they did with long-term care, because it was amazing.
Oh, we do have a program called Project Independence, and we have fewer residents in nursing home care per capita than most of other states in the nation. And we do find that being able to keep our seniors in community-based settings or in their own home rather than a nursing home decreases costs significantly. And so we do put a lot of effort into whether a person needs a nurse to just manage the meds once a week or a caretaker to come in just once a day. We have a very well-developed program, and I would definitely encourage you to think about how you can keep your seniors in their homes.
And be sure and engage your nursing home community or your long-term care community, because if you were like Tennessee, which was very institutionally based, they weren't particularly happy when we decided to go to more home and community-based services, keep people at home. But they have been helpful in building the infrastructure in order to do that, because you just can't walk in one day with an institutionalized based system and walk out the next day with one that's community-based, because you don't have the infrastructure to provide the services. So while you may have a great idea, you have no way of implementing it. So I would encourage you, if there's any folks from the nursing home or long care industry here, engage those people as well, because they really have a lot of value to add to the conversation.
But we in Oregon were sort of forced to be able to have to go to a community-based system, a home-based system, because the reimbursement rates are much higher for nursing home care on the East Coast than it is on the West Coast. So at least in Oregon, we had to find out a different way to be able to take care of our seniors.
So do we have questions from the audience or thoughts or ideas that people are going for? Do we go to the mic, Samantha? Okay, so if folks could make their way to the...
Oh, Lord, they're lining up. We're in
Oh,
trouble
good, I love
now.
it, I love it.
Oh, no.
Oh, they're going to race. I love it.
Senator Anderson, you've done it now. You've got them all stirred
Yeah,
up.
just-
Now they're...
Just a real quick question. You said that the East Coast and the West Coast vary in their reimbursement rates for nursing care. Why is that?
It was a formula set up by the feds again.
Oh, shocking. The federal government set up the formula. How amazing.
And there are far more nursing homes on the East Coast. At the time when this was set up, I don't know the real reason, but at the time it was set up, there were many more on the East Coast in nursing homes.
Okay, thank you.
Part of the formula, correct. Yeah.
I'm Keith Frederick from Missouri. I'm a state rep and an orthopedic surgeon. I particularly appreciated Senator Watson's comments about the total joint. But you made a point, Senator, about the patient really sort of being left out of the equation.
Right.
And also the sort of disrupted relationship between the provider of services and the consumer of services from the typical arrangement in society.
Right.
You know, with the value-based emphasis on compensation now, is there a role for increasing or sort of empowering the patient? The last few years I've carried a bill in Missouri that established health savings accounts as a mechanism of giving the patient some skin in the game. Didn't get much traction, but this year ALEC has a model piece of legislation. They don't call them HSAs, they call them medical savings accounts. But I think that's a way, it's really shared savings, but it's not shared savings with the providers, it's shared savings with the patient. And then the patient has motivation and skin in the game to not go down the road of multiple MRI scans. If they had one last week, they don't want to just have another one done. The way it is now, somebody comes in the office, they had an MRI scan done or a CT scan. Let's say the ER doctor's taking care of them for flank pain. They think maybe they have a kidney stone. Well, I just had a test like that 3 days ago. Well, it's 3 o'clock in the morning. Your EHR doesn't allow you to access the scan that was done a few, so you run another one. But if the patient were empowered with being able to keep a part of the savings at the end of the year, maybe they wouldn't be so interested in repeating tests and repeating treatments that...
Yeah, let me give you a name. Contact Senator Mark Green in Tennessee. He's got an innovative idea. The feds are never going to accept it, but he's got an innovative idea that does that. Basically, it's a little bit different than the model that you've got. I've got Senator Becky Massey down here from Tennessee as well. She can probably explain it better than I can. But basically, he has this idea that we're going to give you a debit card. I'm going to be very general in its description. And we're going to put $100 on it again for our friends from, who have I not picked on yet? South Carolina. South Carolina? Okay. Finally, somebody that's not here. South Carolina. And I put $100 on it, and that's your health savings account, or your health amount under a TennCare system. And you swipe it, and at the end of the month or end of the year, whatever, you got $10 left. You share in that savings. That's one way of doing it. Now, of course, the problem is that humans are capitalistic beasts, right? And since people figure if they show up at the hospital, they got to take care of me whether I can pay for it or not, there are some disincentives that will make people not follow through with their care, not have their regular scheduled appointments. So he puts into some parameters for that to ensure that if you're going to get the incentives, kind of like leasing a car, you got to do these certain things if you're going to lease the car, and then at the end, you give the car back, you don't anything on it. If you don't do those things, you're going to owe something on it. So it's kind of an innovative thought, innovative idea. I appreciate you being here. I appreciate your service, particularly as an orthopedist. You and I know that when patients come in, they never say how much it's going to cost, right? They ask you, is this covered? Because they've brokered the deal through their intermediary. Yeah.
Yeah, and I think one of the things we are seeing some other states that have taken this up, certainly Indiana has their Healthy Indiana. Basically, it gives you access to services you might not otherwise have if you do, as you said, sort of perform on the prevention side. I think that you're absolutely right. I'm not sure how far we get with the federal government, particularly around any sort of emergency or other types of services, but certainly some states have floated the idea of penalties for using the emergency room. if you don't need to. So those have been floated out there. They have not yet been successful, but I do think there are a lot of more on the incentive side. And I think your point about shared savings is an interesting one. If it's on the incentive side, it's much more likely that there's potential for interest at the federal level.
Hi, I'm Jerry Miller, representative for Kentucky, and just going off of the same theme as my predecessor from Missouri, I actually voted E on this because I think it is the key is either incenting or punishing, or not punishing, but at least setting a copay or a reward system. And I just wanted to know if any of you all had tried copays and what you thought about the copay idea as opposed to the incentive. And Bo, thank you for not picking on Kentucky.
Well, I hadn't gotten there yet.
Well,
now I'm there.
In Oregon, we did we did have a copay of $5. Every Medicaid patient had to pay $5. And after a year, we had to drop it because it didn't work, unless we
Well, it didn't
came up
work
with it.
because they wouldn't pay it.
Yeah, they didn't have the
Okay.
money, even though maybe they had a pack of cigarettes outside or
And I
or
don't
a
think-
fancy car.
Yeah, and I don't think the feds will let you collect on it.
It's what it's called. It's called non-enforceable.
Yeah.
So you
Okay.
can simply ask for it, but you cannot in any way require it.
So if you would comment about other incentives that you found do work.
Well, we hadn't found anything that works because we're sitting here talking about this right now. I mean, it's just true. I mean, that is kind of whimsical, isn't it? But it's just true. I mean, we're all struggling. There are a lot of solutions, and there are people. Look,
Yeah. But skin in the game, you're right. It's
Well,
somebody's got to
I
have
tend
some
to
skin in the game
disagree,
here.
Though, I at least the beginning satisfaction surveys of our Medicaid population that are a part of a CCO, and that's where insurers aren't involved. This is a CCO that's being given the money, and then they figure out how to deliver the services. So far, the satisfaction rates have been pretty positive. Again, it's only 2 years of worth of data, so give us 5 years.
Well,
Thank you.
I'm sorry, go ahead.
yeah. Well, I was just going to say the satisfaction rates for our TennCare system are up in the Senator Massey, middle 90s, upper 90s. I mean, our patients are very satisfied with it as long as they get the benefits that they either are or are not paying for. I mean, patients are satisfied. It's kind of like where's my orthopedic guy? He's familiar with the Joint Commission on the Accreditation of Hospital. Patients gives you a high rating if you give them their pain medication when they leave the hospital. Of course they do. I mean, you give them what you give. If I give you what you want, of course you're going to give me a high satisfaction rating. The challenge is, how do we control the cost? Because if you're a state like Tennessee, we've got a $34 billion budget. You cannot allow, the more that Medicaid grows in our state budgets, the more it crowds out infrastructure, it crowds out education, it crowds out any other great ideas you might have.
Yeah. But I think one of the things about Senator can I call Senator Anderson?
Yes, please.
Okay, Senator Anderson. I think one of the things you said that is really important is it's putting somebody else in the accountability. It's very difficult. The federal government is not interested in you giving the enforcing the accountability on the consumer. Which is the issue, right? So, but directly to the provider, we haven't had great success with either all the time. So I think the idea of making communities more accountable is kind of an interim step. It's saying, okay, well, if you guys can get more of the preventive services used, those kinds of things. So it's not the perfect solution, and it's not the consumer engagement model that you're talking about in Tennessee, but it is a half step that I think some people are considering. Yeah, go ahead.
Thank you. I'm Senator Mary Cafaro from Montana, and I have 2 questions for Senator Anderson. One is, with your accountable care organization, I heard you talk about a lot of important pieces of the whole healthcare system, but I didn't hear disabilities. I'm wondering if it includes disabilities. I don't mean mental health, I mean like developmental disabilities or physical disabilities, and if not, why? And then 2, do you send explanation of benefits out to your Medicaid members? Does your state do that?
That's a good question. I don't know the answer to the last question. I do not know. But a lot of our disabilities are dual eligibles, and I'm not, some are in a CCO, but I know that a number of them, we have about 114,000 people that are not in a CCO, and I think some of them maybe are dual eligibles.
Did you include members from that industry in the accountable care organization?
Absolutely.
Okay,
Yes,
thank you.
They were definitely a part of it. Very
Great.
part.
Thanks.
And I'm pretty sure on the explanation of benefits, I'm pretty sure that's now required from the health plans.
We don't have that in Montana, and I've tried to pass a bill because I think if you're going to get at responsibility and accountability, people who have Medicaid need to be treated the same as people who have private insurance and get an explanation of benefits. And also, my fiscal note showed that it reduced fraud because a person who received an explanation of benefits could call up and say, I never received this service. So I don't understand.
That's
You
a
know,
great-
our department puts up roadblocks, but I'm going to try again.
That's a great idea. Is anybody from TennCare, Tennessee, is anybody here that knows that, whether we do that or not? Okay.
Well, I know
we
that-
can do some research too.
We are developing a culturally responsive and population-specific training for providers, as well as they are developing literature, also in various languages. So they're looking at that, but that's another thing which we need to be working on.
Thank you. Okay, great. Go ahead.
Hi, I'm Heather Shattuck's legislative staff from Alaska, and we just passed a pretty comprehensive piece which, includes a lot of the payment reforms you've talked about, actually does include explanation of benefits. But one of the things that, I've struggled with as we've gone to these things and talked about healthcare reform is that everything is about keeping the people where they're at. And the system is built to keep folks in the poverty level. We have expansion in Alaska, but literally if you work a full-time minimum wage job, you're going to make just above expansion. And if you're somebody who's on Medicaid, you probably have food stamps, rental assistance, childcare assistance, heating assistance, and so on. And then you have the side with if you do have a disability and you can work, as soon as you start working, you lose your health care after a while. So have you done anything that looks at encouraging people to go back to work? We know these folks, until they start working or volunteering, they're not going to feel better about themselves. And if they don't get those skills, they're never going to work themselves out of that system, and it's just going to be generational. And I know the feds make it difficult. We put in our legislation referrals to our Department of Labor or Education Services, but I think that's the barrier. Our goal should be getting people off of Medicaid that are able to get off of it in a better level of life, but it seems that the system just wants to keep people trapped at that lower level.
And you're right on that, and there's a lot of work to be done on that. I know that when they transfer from Medicaid into the exchange, and we have a very viable exchange in Oregon, they do get subsidies depending on their income in paying for their health insurance, and it comes from the feds. And so that helps them be able to keep the same services that they have. But we still, the deductibles, when they go into the exchange, they'll choose a bronze plan, and deductibles are $5,000. They have one visit to the ER, and boom.
Hey, Kathleen, you probably know, is a work requirement or work incentive, I'm not sure that we've ever been allowed to do that, have we?
No.
Yeah.
No, I think referral is as
Yep.
far as folks have gone in terms of the federal approvals. Being able to refer people for work supports is now part in some Medicaid sort of coaching in that way as part of the enrollment process and other parts. So it is out there. There are also some programs for people who have disabilities so that they can stay on Medicaid, because Medicaid services are much richer than those in private plans for people with disabilities. So there are work supports that you can use in Medicaid and keep your Medicaid services, but you have to be on the disability phase. You can't be just a general Medicaid enrollee. So I think this is probably one of the most critical areas we still have to figure out. And I think the other one about your comment, Senator Anderson, I think there's the potential for people to be in a really difficult churn situation between Medicaid and exchange coverage. It's not the same. And it is not just from a cost perspective, but from a service perspective and from sort of the orientation of plans in the exchanges. I think these are people who are going to be back and forth, and it's really something we haven't quite tackled in a consistent way. But I think what I really appreciate about your questions is These are exactly the kinds of conversations we need to be having. There's been several references to what the feds will tolerate and allow, and I think that's what we just need to continue to look at and explore together, because I don't think we have good solutions yet, and we just need to keep talking. Go ahead, next question.
All right, thank you. I'm Representative Kelly McCarthy from the great state of Montana. And Senator Watson, I want to commend you, because the most important thing with finding a solution is being able to frame the problem, and you've done that very well, so thank you for that. I think this is probably more for Senator Anderson or almost anybody in the room, but in the last 6 months, most of my work in the healthcare arena has been with that super utilizer population that you had mentioned, and these are 2 to 5% that cost the 20 to 30%. And so what we're looking at is addressing the social determinants that these folks have that are leading to poor health outcomes. And so, Senator Anderson, you mentioned something about your CCOs, and somebody bought an air conditioner and stuff like that. And I'm curious, have you found a solution that will allow a housing as healthcare type of solution? So when they're homeless, can we get them into housing and call that healthcare? Or if it's not happening in Oregon, is there anybody in the room who's addressed this and found a way to do that?
Housing is a huge issue, and we are now looking at determinants to see how that can fit into our CCO, because we do have a big homeless population as well as affordable housing. I mean, I don't know if anyone's from California, but the Californians are coming up to Oregon and buying out our apartments and then evicting our residents, and
Those darn California people.
jacking up the price because it is cheaper to buy in Oregon than it is in California. But no, that's a huge issue. We do have a task force, a metro task force working on that to see if we can somehow work that into our CCO model, because that will take care of a lot of health problems if we get them into a safe and affordable housing.
Thank you so much for bringing that up. I think that is another one of those really pressing issues. The bottom line is Medicaid is not going to pay for rent, and that is the one thing. It's just verboten. We're not going to go there in terms of rent. That's the bottom line. However, and I really encourage you, as Senator Watson said, to talk with your Medicaid director, because there are a lot of components that are called supportive housing, services that can be delivered to keep people. Once you find them an apartment, keep them there, help them understand they have to pay rent, how to get along with their landlords, how to stay in the housing. So Medicaid can pay for those supports, and it's really critical. We don't typically. We haven't taken advantage of that flexibility, but it's one that I think we really need to get better at, because we know this is driving so much. Our ER visits are coming from those people who are homeless. I mean, that's really what is coming from. Our super utilizers are typically not in stable housing. So I think this is a conversation that needs to happen and is happening at a lot of state levels. It is also happening at the federal level, but it's not in the way of just sort of pooling money and everybody's going to be happy, but they are trying to talk about how we can sort of work around it. So I really encourage you to get active on that, because it's going to be one of our critical issues. Thanks for bringing that up.
Thank you.
We have time for the 2 questions.
He's not allowed to ask a question. I don't want this guy asking questions.
Well, I'd just like to make a point of clarification that leads into my question. The
Lord.
10-care survey that they quote that shows 95%, actually terrible methodology on that study. They actually use if you look at their HEDIS surveys, it's closer to 50 to 65% satisfaction rating. So just, but that leads into my question, because
I told you I didn't want him sitting up to the microphone.
Don't need the numbers, Kathy.
it leads into my question, because we try out all these different reforms and these innovations. I mean, we have our payment reform in Tennessee, and particularly when you're looking at something that is a multi-billion-dollar budget, that is usually a global budget. I don't know if every state utilizes a global budget. I know we in Oregon do. But what you'll see is, for example, ours was a $10 million savings, really round number. That's awesome, kind of coincidental. Then it's also on the same page right next to a $150 million increase for this just amorphous healthcare inflation expenditure. What kind of data are you going to request from should legislators be requesting from their Medicaid programs to actually be able to demonstrate that it's the innovations that are leading that are actually realizing these savings? Because when you utilize a global budget, sometimes it's hard to really isolate those parts, and it's a complicated thing. I just wondered what y'all thought about that.
The CCOs are paid per per member per month, a set fee. And they have to then, for the following year, that amount cannot increase more than 2% per member per month. So far in the 2 years, our CCOs have been maintaining that. It had been 5.4% per member per month each year. They have decreased it 2%, and they're going to decrease it 2% for the next year. So that is a metric that they must meet, and, you know, time will tell if they can sustain that.
Okay, one last question, and we'll need to make it quick so we
Okay.
can wrap up on time.
Thank you. I'm Janet Habler, registered nurse and staff with the American Nurses Association. And my question is for Senator Anderson, and it has to do with metrics. You alluded to changes in the kinds of outcomes that you were measuring. And if you could just elaborate a little bit, what did you let go of and why, and what did you want to add or did add?
I wish I knew exactly which ones they took off. It was just in the last year. They took off 3. I don't know, Kathleen? No, yeah. But they did add dental sealants, and I forget what other one that they added. So, again, it's on the website, all the metrics that you want to take a look at. But along those lines, I'm on a school funding. I want a nurse in every school, okay? So I have to put a plug into that. And
Thank
we are
you.
looking at funding for that also. But we found that one school district, they do bill for their services. They have one nurse, and they bill for their services, and they only focus on those patients where there is good reimbursement and they are able to fund their school nurses just from by billing Medicaid.
Interesting. Great.
That is something new.
Yeah, thank you very much.
It's certainly worth doing some follow-up and looking at both of these websites and finding out more and asking these folks throughout the meeting more detail. Just want to remind you, we talked a lot today about a lot of different concepts. Payment reforms, data and metrics, I think, is really critically important. And the oversight and accountability, where is the accountability? How do you activate the accountability that you have and get new accountabilities, as we talked a little bit about with consumers or providers or community groups. So really just a whole array of options for you. I'm going to turn it back over to Representative Weaver for some housekeeping, but I'm going to leave up this poll here as a way for you to sort of give us some responses in terms of just give us a couple of words about where you think your state is going, and really find really useful. Please join me in thanking our panelists as well.
I do want to thank our panelists for a job well done this morning and that great information. Coming from the state of Alabama, I'll tell you one of the challenges that we continue to face is the cost of innovation, because we continue to do a lot of both the things that we talked about, and we're really struggling going into special session again on Monday, trying to figure out how to fund transitioning our innovative system to the innovative system. So I know that we all have different kinds of challenges that we are facing related to Medicaid. I'd like to thank the Health Resources and Service Administration for sponsoring this session today. I know it was very informative. Next, I'd like to invite you to join us in room 187 to learn everything we need to know about the Zika virus. So we will start that promptly at 10:30. Room 187 is just out the door to the left, and this will also be followed by our session on prescription drugs, which will be in the same room, and then we'll be back in this room for our committee lunch program. Thank you again for attending this morning.
They love that.